So I
So,
shall.
so your commute was um a hour and some.
Yeah, it was 2 hours. It was just over about 2.25 hours,
On a good day, it's how long?
an hour and a half.
And you listen to Gresham audiobooks, or is it all work and no play? So you're dealing with
Well,
philosophy and
no, just I do. I listen to Radio 4, we call it.
Radio 4.
Yeah, that's the news channel here
Ah,
on the
very
radio,
good. Very good. I
like our version of Fox.
Oh, okay. All right. Well, then I should ask you about the news stories I've been ignoring, and or at least trying to. And anyway, it's I find that I enjoy life a little more when I talk to people like you and focus on things that I can try to act like I can control and
Yeah, as
see
opposed
where.
to people murdering each other.
Yeah. Yeah,
Yeah.
that. And the family's good.
Yeah, they're out and about. You may hear some screams later when they come in from cubs and
Oh, that's right. That's right. That is
uh,
part of that stuff. I had originally, I guess you could tell, I had a little bit of a text burp to you there. I I think that maybe it would be good to consider the different approaches that we are having, maybe different exposures that we have to this tool of musculoskeletal ultrasound. You are looking at the people who are on your queue. Um, are the majority, are all of them there for you to do a first screening scan of what the pathology is related to their pain, and then determine whether or not you're going to um, direct that to further specialty care or provide your own intervention there in your service? Your eyes, are they looking at first pathology, and second, is this pathology a condition I can treat?
yes, sort of. It's they'll often have come from somebody else who's had a look at them, possibly had a previous treatment, and they'll come then for a view as to confirming the diagnosis and then going on and treating. And that would be a lot of my work is where there's an expectation, like a frozen shoulder or something like that, or Morton's neuroma, or something that would benefit A from the diagnostics and B from an injection. And those are people who are normally filtered towards me.
As you set up your encounter with the patient, is there a 5 minute take a hold of their arm, or could you show me what you can do, miss, and then take a hold of the arm? And do you check anterior posterior glides? Do you see what the end feels like? To what extent do you implement orthopedic manual testing prior to your scan?
Well, I do a little bit. It depends on the story because I I listen to I ask the patient what's going on. I've usually got notes of someone who's already done that. So I've already read what quite a senior colleague
Yeah.
has already thought about it. And I guess I'm prejudiced towards the ultrasound. So I don't spend a lot of time with a lot of that because I don't find it valuable in my work. So when I'm looking at a shoulder, I'm more interested in the little things like their external rotation, just as I move, their true external rotation and abduction. And that's all I really care about after I've heard their story. So if you come to me with a fairly straightforward story, your shoulder hurts, how it started, and how it's progressing, and how it affects you. After that, I actually only really want to know, because I know whether it's weak or not from what you've told me. and just you're getting your shirt off or whatever. And then I really just want to clarify that by understanding whether I think there is what we'd call a capsular pattern. So I'm not going to do any funny movements with it. I'm not going to test anything in detail, because actually I'm going to get my answer from the ultrasound in combination with the history.
If we took a look at your entire encounter from patient walking in to patient leaving, would we say that that preliminary question, tell me your story type thing, would that be 10% of that pie, or would that be 20%? I'm just trying to get a picture of the preliminary compared to how much meat of scanning do you do of that pie?
Well, it does vary, and if we're talking strictly about my sort of where I'm managing the patient, not a radiology scan. So in clinic, then the patient's walking in, and if they've got a frozen shoulder, I'll sit down and they'll just in a couple of minutes. But I've probably already I may already have started scanning by the end of it all. So I'm basically saying hello, developing some rapport, just as you would in the first few seconds.
Right.
And you're here to see about your shoulder, how long has it been troubling you? I've already read much of that story from the notes, because we get quite extensive notes, and I tend to read them. And then but I've probably told them to, as they came into the room, it's sit down, put your things there, slip your shirt off and sit in the chair. And then, once they're sat down, they're telling me what's going on. Then I'm just moving the arm into external rotation to get an idea of which of the three shoulder diagnostic patterns you're looking at, and then I'm scanning, and I scan for as long as I need to get to where I want to. So the actual talking might be just a couple of minutes, barely that.
And after you have done the scanning, where I'm assuming you're doing knob pushing or foot plate touching or whatever, when you've collected your data in whatever form you're collecting it in for your reporting, at the end of that service, as you're taking the gel off, is there any post-scan debriefing with the patient, or do you say, I'll get this report to your doctor, have a good day?
No. There are two different worlds. In radiology, I do a very deep. So if I'm doing a radiology list where I have 10 minutes per patient, then I'm giving them a brief synopsis of the scan results as they're getting off the bed and getting dressed. But when you only have 10 minutes per patient, they don't get any more than that. If they want to talk about what we do about it next, it's just chat with your doctor. In the other scenario, the other 3 days a week where I'm working in clinical practice, then I may be talking to them as I'm scanning, unless it's something technically difficult, when I won't. But I'm explaining to them what I think the problem is, and we're discussing what we do about it.
When you say, except for when it's technically difficult and then I don't, are you saying except for when the scan requires technical placement and all that kind of stuff? Or are you saying when you see a fracture that's pulling up blood as you move the shoulder around?
There's an element of both, but in practice, when I'm in the particularly in the discovery phase of a scan, just trying to figure out what's going on and make sure that you've covered the bases, then I just do that better if I don't talk. Or more precisely, I can talk, but if the patient, so long as the patient is not asking me questions, then I just scan better. I make less mistakes. I see more stuff. If my I've got an old 286 chip in my head and it's only got one channel. So basically, I can probably keep up a patter without requiring very much memory, but I can't answer questions, and I will say that to them. I say, I'm afraid I don't multitask, and I make far fewer mistakes when I don't chat. but that's the reason I'm not chatting as I'm going along, and I'm not explaining what I'm seeing. In that scenario, where I have 30 or 40 minutes with each patient, then I want them to involve in the scan. I want them to understand what we're seeing, because I'm going to put that into context bit during and after the scan to try to come to a common understanding as to what's going on and what we do about it. So yes, that in that scenario where I have the time to do it, then it is the whole process that I'm not giving a report. I write a report in the notes, but the report goes to the patient. Is the patient there? And it's and it leads to our joint management strategy. You know, I'll be talking about the bursa, I'll be talking about tendon, we'll be looking at the tendon, I'll be saying, well, you know, if we do a steroid injection, that tendon looks, there's some deterioration in the quality of the tendon. That may be compromised if we do, this is what we're looking at. That may be compromised by the steroid to a degree. And that's a part of the risk analysis, risk benefit choice that we make if we decide to go and do an injection. Or we say the tendon looks great, this is going to heal well, you may want to consider not having a steroid injection at all, but then the risks may be here, there, or everywhere. So these are the sort of discussions that I have while I'm scanning in that scenario. So the ultrasound is definitely something that I'm just trying to get them to understand, just like I'm understanding it for a lot of the time.
In the clinic.
But, yes, in a clinic scenario, as opposed to a radiology scenario.
And in the radiology scenario, you had said 10 minutes. What is your list of clinical or clinic? How long is that encounter?
The 30 to 40 minutes in practical terms, including all the notes and all the paperwork.
You're with the patient, though, maybe again 10 to 15 minutes.
No, usually about 20 minutes at least.
Okay, all right. So we're not so far off with your last scenario as to how I'm set up in what I'm doing, but I'm attempting, because I am going to be vulnerable enough to share with you some of my scans, and you have to understand my paranoia with how the quality of that scan does have me want to talk for a long time up front. So I cut myself.
You don't need to.
However, John, I need to tell you, I'm far more coddling of curiosity here, because these people can tell their neighbors, and the more charming I am and the more informative I am, I truly do. The marketing occurs when I deliver the best I can. When they look at that and say, why does it look that way? I almost at times encourage this so I can sound brilliant. I want to be really brilliant and not make up stories. And so when I ask you things like, why does it look that way? It is many times in attempting to collaborate with somebody whom I trust and say, yep, we're both making that up. Or we have no idea, or you know, and I don't mind saying I don't know to a patient, but there are times when I would like answers, even if those answers I wouldn't be sharing with the patient because of that concept, you know, of their coming on board. So I have a half hour. I spend maybe 5-10 minutes just getting a better picture of it. Most of the time, I don't have any history on these people. They come in with just saying, I have a knee pain that hasn't been responding favorably to therapy. And they'll come in on my queue that'll just say knee pain. And so I'm trying to limit the scans to a certain area, shoulder the same and all that kind of stuff. And so part of what I have 4 scans that hopefully I can get to if I hurry up, and our internet is fast enough to show it to you. And if I don't, I'm going to turn it back over to you and say, until I figure out this thing, share with me. But I have 4 different scans that I would like to just go with you through some things and say, John, in the event somebody pressed you to say, why is it like that? And in addition, I might ask you, where are your eyes looking now in this video? Because I would like to have that, you know, I would like I would like to not be a person who gets fixated on a single spot in a video and can back up and say, whatever. Are you with me on that? Are you
Yeah,
anything you want to share
yeah.
ahead of time on that?
No,
All
that's
right.
good. Let's get in.
Let me see if I can actually get this to work. And I don't know if you're seeing
Yep,
this type of thing. Let me first ask you. No, I'll get right. I'll worry about the other stuff later. And let's see if are you seeing a bunch of videos showing up here?
yep.
Okay. I'm going to try to activate this one. I don't know whether or not it pulls up.
Yeah.
Are you seeing a video at all now, or are you still seeing that grouping of
I'm
videos?
still seeing the grouping.
All right. So I think I need to stop share. I need to go back and share and see if yeah. And I'm hoping now you're seeing
Yep,
the full and you're seeing short axis long head of the biceps tendon.
yep. That's
Um,
good.
all right, now let me see. Are you seeing it move?
Yeah,
Okay, so I'm going to actually pull this back a ways, and
yeah,
the first question I want to ask you is, on either side, the lesser to the right and the greater to the left, as we go through that bicipital or intertubercular or whatever groove, as we go through there, and you're starting to see on the left um, areas where the periosteum starts to give us gravel or what
yeah,
looks like peaks that are going up and down.
yeah.
Um, is that wear and tear? Is that traction erosion? And does that play into the background of what you're already setting yourself up to find with the supraspinatus tendon, or is that just
Yes, basically. It's happening as as you're going from the one end of the enthesis to the other, one
yes?
border of the enthesis to the other. So there is an element in which the cortex is not going to necessarily be as crisp as it is in any other point, because it's at an angle to the scanner. But yes, it looks irregular, and so I'd immediately be suspicious that there is some degree of abnormality there.
Now, this is not unique to just this. It is a function of all entheses or where there is the possibility of breakdown. And it seems a function sometimes of just plain periosteum, like over the top of the patella. It can give us this asteroid like, a breakdown. And I'd like to talk to you a little bit about that. Do you see the hypoechoic point in the stopped video right now to the left with the two sharp things, almost as though it looks like those are sutures from a previous surgery?
Yes, there are two bright spots against a dark area
Yeah.
of anisotropy.
Right now, in looking at that, is it just in your mind saying, okay, there is tissue that will echo sound that is in a space that could be more along with the anterior fibers of the supraspinatus, but we don't know for sure? Or what do you do with that? Just keep moving?
Well, at the moment, there's no certainty that you've got rid of anisotropy there.
Okay.
So the two, wait a second. So the two dots would potentially represent two areas of calcification, because if there's anisotropy making that area dark, which you'd presume that there was, because you can't see, because there's no loss of shape. You've not lost the shape of the of the bursal layer, and so to have two black dots like that in it would suggest that there's some small areas of calcification, which are not necessarily clinically significant, but that would be what you'd immediately jump out at.
Are you aware that you said black dots?
Sorry, yeah, I didn't mean bright dots.
Oh, okay. I just wanted to make sure that your mind wasn't thinking that black correlated to density. I'm just trying to be critical as to what your thinking is. As we take a look at this, No, and I don't mean to point out that. I just want to make sure I'm on top of what your mind is processing.
Yeah,
Um, this again is short axis, or at least part of
yeah,
the long head of the biceps is refined a bit. As you
yeah,
see this grayer scale down
yeah,
and to the right, are
yeah.
you in your own mind, are you saying, well, that could be the slip of the supraspinatus that they talk about, or that could be the superior glenohumeral ligament, or are you just saying, leave it alone, Fritz? That's just in the region of the long head of the biceps, and there are times when the fibers don't get refined like the rest of the fibers. That's nothing to you. Is that correct?
It isn't necessarily nothing. It depends whether it's continuous as you go up and down. The fibers of supraspinatus that go over the top of the tendon tend to go over the top of the tendon. So this could be part of the pulley mechanism, or it could be a separate part of the biceps.
Yes.
Sometimes the biceps is there. It in that single shot, it looks very prominent. You know, it looks very real. But I'd want to just play with my angles and
Yeah.
go up and down it.
And off to the right now, we're knowing that this is going to be more of the distal insertion of the subscapularis. But as we're seeing this same topography here, you're just saying that's an aging enthesis.
I suspect it is it looks like a pretty ropey old lesser tuberosity, which you often see.
As I'm looking over the top of this like this, and are your eyes looking at all for thickness of bursa, or are you saying, no, I only really care about bursal thickness if I'm seeing evidence that there could be fluid in there, or that's just a non-issue right now in your scan?
It's I'm at the moment I'm just going as you're coming up at it, I'm just getting a feel for what the shoulder is like, but also saying that yes, it looks like it might be a little bit thicker than you'd get in a 21-year-old, but in combination with the couple of changes you've already seen, a little bit of thickening of the bursal plane,
Yeah.
Or actually the capsule, because as you come up higher, you know, you're into the joint, and there'll be elements of capsule coming over the top of biceps at that point.
I just tell you, John, my brain, my brain is an 80-88, and when yours a 286, you claim,
Yeah,
I'm looking at this, and I say to myself, I forget sometimes where the capsule is when I'm looking at the rotator cuff, and my
yeah,
mind, anyway, I'm going to keep going here because again, I'm now continuing up and over. I'm going through at least the plane of where I think I've resolved as best I could the long head of the biceps.
yeah. That's
It
a good
looks
shot.
thickened to me a little bit as I'm coming up and over. I attempt at times to turn and let it go medial. I believe I bias in the direction of letting my patient just sit there rather than getting the acromion out of the way like good imagers would in order for me to see the infraspinatus and all that. But I'm going way up and over. I'm now about ready to call it good as I go over. Looking again, I'm coming back down now, and that's usually part of my first scan. I find pec major. I then go inferior to see the biceps muscles, see if there's any atrophy down there, and then I start working myself up. And so that's that. Let me go to another one. I don't know how I shift. By the way, this is very valuable to me. I don't care if it's value to anybody else. How would you get me
There's
to
an
the
X in the
next?
top corner.
Yes, I would click on that.
Yeah,
Uh-oh. Now I need to go. I want to share another one with you.
yeah.
Let me go back and say, oh, I'm going to have to do this over again.
So,
And you're not seeing that, so I'm going to stop share.
no, I was seeing the page with all the little film things on.
But you were not seeing this, right?
No.
Okay.
Uh,
And again, now what I'm attempting to do is I'm going to take a look at the subscapularis. So
yep.
coming up, I'm looking to see that there's no large compromises in the tendon, but
Yeah.
I am seeing that topography. Again, that's not there when I'm looking at a younger,
No.
a lesser tuberosity. And that represents what, John? Aging?
Well,
Is that extra pulling of forces on fiber in the body is remodeling for that?
Yeah, we've never really X-ray doesn't really show OA at the anterior margin, and so we tend to and so because it isn't always very symptomatic, we tend not to take it too seriously. But I see this and the alteration in the shape of the humeral head when you're looking at it from the front as a marker for a degree of OA, even if it isn't the most it isn't the sort that gives you the most symptoms. But I would describe this much in the way you see if you look at a 70-year-old knee. It's quite unusual to see those nice tight articular edges.
Yes.
That you see in a 21-year-old. You do sometimes see them in 70-year-olds, but usually you don't. And I feel a bit the same way until you actually see clear lipping of the
yes.
Of the anterior border of under subscapularis. I tend to, look at it, think this is not a new shoulder,
yes.
or this person has done a lot. Sometimes the people who've boxed a lot will have quite an atypical shape.
Yeah, interesting.
There, and or something similar. So you look at it, you notice it. I don't necessarily say a lot about it until.
So is it part of your general scan? Is a subscapularis assessment in long and short axis? Yes. And while you're now looking at the long axis, and we're seeing kind of those conjoined tendons of pec minor and short head of the biceps and all that, do your eyes spend time over here at all as you're looking at the coracoid, or is that kind of a non-issue?
Only insofar as when I'm having a look for the coracohumeral ligament, which I do just as a routine, as it's part of my routine. But you don't see pathology in the short head of biceps. I don't look for pathology in the pec minor. The only thing I really see is in some frozen shoulder presentations, there seems to be a variant where the coracohumeral ligament is thickened, but it's also continuous with the pec minor.
Coracohumeral ligament is continuous. Yeah, I got to get my head around that. They're going to take longer than I have right now, John. I've got to.
Yeah. Well, I'll show you some video, but it's quite funny. You think this patient's got a frozen shoulder. You think it's the coracohumeral ligament that's causing it, and actually the coracohumeral ligament is not attached to the coracoid. It's actually attached into the pec minor.
So what you just
not uncommon.
In that last sentence you just gave, I want you to know that what you've told me is that you have an algorithm that you would be able to give to me that says, here is an excellent example of an objective frozen shoulder, and here is why this other example is not frozen shoulder. You have criteria that involves anatomy, that if there is a common multi joint presentation, this gives you confidence that this person is dealing with a frozen shoulder. That whole story I want to have for a single encounter with John's brain.
I didn't quite understand what you were saying.
Let me try again. In your last sentence, you so confidently said, this we would call frozen shoulder, and you were just looking at the coracohumeral ligament. I want to drink that in, because I know that there's also other criteria that people will use, including the movement of the posterior window of the humerus. I'd love to have you give me multiple videos.
Maybe I have some videos of coracohumeral ligaments tightening up, I'm sure, somewhere. But a frozen shoulder is, to me, a tightening of the capsule. It's often the coracohumeral ligament. It's often the inferior capsule. It could be any piece of tissue in there at all, because it's just part of that sort of Dupuytren's complex of presentations.
Yes.
But it does have a classical feature of restriction in external a restriction of external rotation, and it's that where I see it, where I feel that loss of movement there, where the X-ray is normal. where the abduction is also typically restricted. That is the scenario we see over and over again, and where they haven't responded particularly to a subacromial injection, and where physiotherapy has made them a lot worse. All these things fit in and makes me think this is a frozen shoulder. And then you're looking at the coracohumeral ligament to see if and the inferior capsule, which are the two parts of the anatomy that I look at.
So that what you just outlined there is what I'm saying. I would like to have, I would love to have your sonohack guy take that and say, if your clinical impression is that this person is dealing with a frozen shoulder, these would be the money shots that I would have. And here are examples of someone who absolutely does not have. And here's examples of somebody who I think does have. That's what I'm trying to say. And in your sentence to me, you so confidently just said, well, you know how in frozen shoulder, and I didn't know how in frozen shoulder. And that's what so I'm going to keep moving on here. This is short axis subscapularis. I look at it. I don't know what I do with it. And I don't know what happens when I see, the structures again, showing us what I would think to be OA, but I save it because I save it. I'm going to move on to the next thing here really quick. I wish that I knew how to stay in this window as I would go to the next window. I'm sorry about the logistics here, John. Let me see if I can go here. I'm going to go to, I think this is the one I want. I'm going to now go to share. Thank you for your time again, John. So let me see if I can orient myself to this. I think what I'm trying to do here, John, is refine the coracoacromial ligament. And then I think what I try to do is I try to keep my probe on the coracoid. I move a little bit posterior on the coracoid, and I turn the other part of the probe toward the humerus. And I think, at least that's my attempt, to try and record coracohumeral ligament. How would you refine that? Let me see if I can pause this. This is long head, correct?
Yeah.
This is humerus, correct?
Yeah.
And this is coracoid. But what I don't know is what your logistics are to refine.
I can't see it there.
Okay. Oh, that's important for me to know that.
Yep.
We do not have any component of the coracohumeral ligament there.
Not that I can see.
Okay, no. Quit being so gentle, John. You're just you can be a little US and say, yeah, that sucks. If you think that's it, you're robbing them. So what I want to have again is I want to have the confidence, at least, that I'm imaging the thing you're using for the criteria to diagnose.
Though a note of caution, I do not see ultrasound signs in more than half, maybe 2/3 of the patients that I consider to have frozen shoulder.
Interesting. Well,
so that's why it's not a reliable test. Can I quickly share with you?
Oh, yep. Yes, I think I've given you control to just take it over.
Okay, let's go. And sorry, I need to share screen. Yeah, let's share. And we go. There we go. And tell me if you can see a screen there.
Yes.
Okay. And just move. There's a way to move this. And you are sharing. I might need to change screens. There's a way of pulling this down to the bottom. Oh, there it is. Done. Good. So, right. Can you see my image there?
Yes.
Now, why is it not? That's it. Yeah. There we go. And similar shot to yours. Can you see where my arrow is? That's the coracoacromial ligament.
Yes. Yes.
This is the coracohumeral ligament.
Okay.
Yeah.
So
darker.
I would not change the coracoid location of the probe. If what would I rotate it toward the humerus?
Now let me see. I was not coracohumeral contralateral variant. Shoulder. Let me try again. Let's see if this one is any more of. Oh no, that one's really dark. I just give me a moment. I will go frozen shoulder. That's probably better. Yeah, just a short clip there. Can you see? Can you see that big enough, or do you want me to make it bigger?
No, I can see what you're talking about, because the darker in anisotropy, the thicker is your coracohumeral ligament. The one over the top of it again is your coracoacromial.
Yeah. So what I've done here, you don't have a view of the humeral head here.
Yes.
And that is because the fibers are oblique. So if you're seeing the coracohumeral ligament from the coracoid, then the humeral head is not going to be in an imaging plane. So you're going to be scanning obliquely on that. So this just looks like a mess here in most cases.
Okay.
So you haven't got your high on the humerus, and you're looking at it in a plane that is not compatible with viewing the humerus on ultrasound. So
but
what
you expect to keep the coracoacromial ligament in view?
No. The coracohumeral ligament, the coracoacromial ligament, if it's in view, that's not relevant. It might be in view, but you are looking for the plane of the coracohumeral ligament, and you're also coming away from the tip of the coracoid. So you scan it like, imagine you're scanning a finger in short axis.
Yes.
Yeah. So you imagine the coracoid is like a finger.
Yes.
And you come back along it, and then you're pitching the probe, you're turning the probe to head up towards the top of the humeral head, essentially to the interval.
Okay.
So where the interval is, but you won't see the interval because it will just be a mess because you're completely oblique on it at that angle.
I'm with you.
Yeah. So you're up towards the base. You get sometimes quite close to the base of the coracoid.
Yeah. Do you measure that?
No.
You just comment on it to say it's thickened.
I just look at it and I sometimes compare to the other side if it's ambiguous. I see it because the thing is, I wonder how many people have an element of the condition on anyway, even if they have no symptoms. They have, they're Viking genes, and it is thick. And certainly when I've spoken to surgeons, I remember talking to Len Funk about it, and just saying it's it's so variable in its appearance. Normally it's either thick or thin or whatever. So that's why unless it's really thick, and sometimes it is, or in the rare occasions when you actually see a Dupuytren's type nodule in it, you can't use it as a firm fix. But I like to see it tighten when if they've got restricted range of movement, particularly if it's ambiguous as to what the cause is. I like to see it jump taut.
Yeah.
And and look like it is what is limiting external rotation, as opposed to some big osteophyte on the back, which I might go and look at if I'm not sure whether this is more frozen shoulder than an unusually young OA or something like that.
Right. Fascinating, John. Run this again. Do you get this one taut? Yeah, it does look like it does tighten up there. Fascinating. Yeah. So on your scan of shoulders, and you've refined the coracoacromial ligament, how much time will you spend attempting to get a coracohumeral ligament? Or even if you do see it, it is not definitive, it's just part of a group of conditions?
It's like some of those classic neurological diagnoses. It's just part of the story. And I just roll up. Once you've got the swing of it, you'll see it. You see it quite happily all the time. So
I want to get the swing of it, but I want to spend that time when you have multiple times to go, okay, it's there. Okay, it's there. And what I'd like to do is I'd like to pull up that complete anatomy at the same time and make a line on top of a shoulder to say, this is what you're doing, so that I have a better idea of that. So I'm going to just continue here because I'm tapping into your brain, and I'm not even going to get through one case, and I told you I had 4, and that's perfectly fine because, again, I've been vulnerable enough. This is an AC joint, and I'm going to run a little bit of it. You can see this okay with this being the acromion, and the amount of fluid here. Does that bother you? I mean, not in my image here. But as you're looking at it, are you looking for that geyser type thing? Are you looking for a cystic type thing to simply comment on it, or what do you do at the AC joint?
I used to joke that that my report on the AC joint was basically based on whether it hurt and whether the patient had the pain there. So that if I was going to describe that objectively, the capsule doesn't bother me in the slightest. The joint looks quite tight, so I would say that was a narrow joint.
We don't have a disc or any kind of a fibrotic.
It's like a nice old-fashioned OA knee.
Okay, I'm with you. Where there's no meniscus whatsoever.
There's nothing there, and that might be an illusion, but basically it's AC joint appears normal for age if it doesn't hurt, and OA changes and a tight joint if it does hurt.
I'm with you. I'm trying to rush through these because, again, I would like to hear your comments on them. We're now dealing with the interval view, or at least what I'm going to call that to a certain extent.
Yeah. Well, you've got the biceps there. So
as we look at, as your eyes are right here, are you at all assessing subscapularis, or are you just saying, I wonder if Fritz is going to use the slice thickness here remotely well, so I can refine the fibers?
Well, I don't know whether you remember, but there was a time when Pavarotti used to sing with I think Carreras and one of the other guys, and they sold themselves as the 3 tenors.
Yes, no, I remember.
This I call the 3 tendon view, because all 3 tendons are, when you have the arm in extension, if you're looking at supraspinatus, but looking at supraspinatus, then the 3 tendons are on a little bit of a stretch, and they actually pull to be almost parallel to each other, like 3 fingers. The leading edge of supraspinatus, the biceps, they're all basically going in the same direction next to each other. So you've got, in that view, almost a short axis view of all those tendons. And so I do look at it. I do like to look at it. It gives you your first hint of what you're dealing with. And if you have got a lot of thickness on the subscapularis side, I would then go back and look again quite closely at the subscapularis when you're coming up on your biceps, when you're doing your short axis of biceps. As you dip it out of the groove, then you actually should see on a nice tidy scan, you should see just a thin bundle of the top fibers of subscapularis sitting, nestling under the biceps tendon. So you just get the very most.
Those fibers are not what some people call the SGHL, or the superior glenohumeral ligament.
They might be. It's a similar sort of area.
Yeah. Okay.
But you can usually track those into the most superior fibers of subscapularis do blend in, or at least to my eyes, they do blend. Just attach into the under the biceps in a very normal subscapularis. Those top fibers just attach in below, and you see this bundle coming in of tendon fibers.
Are your eyes looking ever for dimension of articular cartilage when you're in this area, to at least take a look and say, hey, it's often very untidy. Gotcha. When you when you're coming through here and you're attempting to refine out um anterior supraspinatus, et cetera,
Yeah.
are you looking at all for the hyperechoic area that I'm refining right there? Is that close to
Yeah.
where
Yep.
anterior fibers would be?
That is the anterior bundle of the supraspinatus.
There
And
is, I'm sorry to interrupt you. I'm just so eager to catch your brain, John. There is a hyperechoic area between where I am now.
well, if you stop it there,
Yes.
the picture is not great. And
Okay.
I don't know whether how much of that is crossing the Atlantic.
Okay.
But
It's not that.
what you
It's
have,
me.
if what you've got is if you're coming down past the deltoid, you've got that thin bright line for the supraspinator, for the bursa. If you leave
Yes.
it still there, and then you've got a bright area and a dark area, a bright and
I'm
dark
trying to
area just
pause
below
this,
that. Yeah,
so I can try to
yeah,
follow through what you're
yeah.
saying.
Stop there.
Right there,
Yeah,
you're
that's
saying
perfect.
this is bursa.
Versal plane, and then there's a sort of diamond-shaped blob underneath it, bright blob. Yeah, that's that. That to me, and the dark area around it, the darks, yeah, that thing is probably a mixture of anisotropy and brightness from that leading part of supraspinatus. The
Okay.
bit below it, if you could imagine that as a line going across the screen, yeah. But no, just that short bit immediately under the diamond. Yes, I think that is continuous with the bright thing going over your anisotropic delta. And I think that's the sort your capsular layer.
Oh, oh my goodness. This is the reflective area of the capsule.
Yeah.
Because we know that the long head is within the capsule.
Yeah. And on a nice scan of of an attract and you know with when you've got the that young shoulder
yes, yes,
you can see that, you can follow that plane clearly. I'll dig out next time I see one. I'll video it.
yes, thank you.
I will show you. But you see that almost you know the two tendons, the biceps and the anterior thing, and then you've got the capsule snaking in between them with its fibers aligned in that direction.
I will be looking for that. And that I believe will help my brain with remembering where the capsule is in that slice. I want to spend a little bit of time with you, John, on saying how much value do you put into having that hyperechoic echo above the articular cartilage here? To what extent will you use this to determine the quality of tissue above it when you're taking a look at tears like posterior supraspinatus, et cetera, et cetera? Is it
in theory? I would take some notice on it. In practice, barely at all.
If this sunk down, if there would be some evidence that you wouldn't have space occupying tissue, it would increase its relevance?
Yes and no. It depends on certainly on the scanners that I'm driving on. Then I can usually see the tissue in there. The cartilage sign was a product of its day in the before the relatively modern advances in imaging quality, where for various technical reasons you often couldn't make a lot of sense of the tissue quality within the cuff, but if you got a nice bright line from if you showed up the cartilage, then that implied that there was fluid immediately over the surface of the cartilage, giving you that bright boundary.
Yes.
So the difference between cartilage and tendon is less than the difference between fluid and cartilage, and therefore the brightness of the line increases. With the modern scanners, if you haven't whether your probe is horizontal to the is parallel to the cartilage,
Yes.
you will often get that cartilage sign just because of the improved contrast resolution on more modern machines, and so it's less useful, or in practice you will see the contrast between the tendon and the fluid, and so you don't need the cartilage sign.
Understand. The fact that this is hyperechoic might it be enhanced because of the fluid content within an inflamed tendon?
Yes, yes,
and that it would be more of a tendinosis induced reflectivity, as
yes,
opposed to if it was a very bright tendon, providing I was truly at the angle of incidence of these fibers,
yes,
might
yeah,
not allow me to see this particular area.
yeah. I think so.
I'm going to see if there's anything more on this I want to share, because I do want to get to a final thing with you. Let me see. All right. I hope this is it. And I know you're not. Yeah, okay. Let me pause this. I'm gonna unshare. I'm gonna prep you to say that I watched a video with Bird talking about the way he looks at the supraspinatus more in a long axis. This is a short axis. Upper trapezius is up here. Supraspinatus is here. And he looks for a fatty layer
Yes.
close to the glenohumeral joint that he feels gets larger. What this is unique to me on, and I'm going to pull this back a little ways, and I'm going to run it in video fashion, but I'm normally used to seeing fascicular echoes involving this entire area that my mind sees as the supraspinatus bed. So we're short axis supraspinatus on that superior, whatever they call that, supraspinatus fossa. And I want to just, as I'm going through this, it's interesting compressing it, that the component of supraspinatus seems to me like it's over on this area here. This normally goes all the way across on the scans that I normally look at here, and with compression. Is this fatty to you?
It does look like fat, yes, and I'd have to have a go and see myself, but that's not the fat he's talking about.
He's talking about it in through here between upper trapezius and supraspinatus.
Yes.
I do have another scan of that where I was going from anterior to posterior. Let me see if I can quickly find that, and then I'll go to my final one. And thank you for your time. Let me see whether or not. Oh, drats! Yeah, I think I'm more. I think I want your brain more on this one than on me looking at that other thing. Let me stop here. Go back to here. I'm going to pull up. Now, this is going to be a dynamic abduction. I don't know if you do dynamics to see whether or not you have active impact of the humerus on the acromion. But as I'm prepping to do this, acromion top right and the humeral facet, or the tuberosity there, and I see this periodically. What is, and come on, let me scrub this here. What is this?
Yeah, that looks like they almost look like erosions, but you see them quite a lot in the shoulder, just at the articular margin. We've never really got very excited about them. We see it sometimes with calcific tendinosis, sometimes not. If I saw that sort of thing in some joints in the hands, I'd be thinking erosions. But you get them, little almost like eruptions of little cortical cysts or things like that. I don't know what they are, and nobody seems. Whenever I've talked to people about them, none of the surgeons get too excited about it.
So we have the rotator cuff on
Yeah.
the enthesis bed here, and
Yeah.
the articular component is here. And so you're saying at the margins,
Yeah.
right here, we can get these little
Yeah.
caves or
Yes.
pits in
Yep.
here. I have seen fractures present themselves in this spot.
Yeah. Yeah.
But this isn't even remotely close to that. Your eyes see this as if there would be a fracture that was reacted, there'd be fluid up and through here, and there would be there would be pain. Yeah.
And it would be a different shape.
And it would be a different share with me that last part as I pull
Yeah.
up the final
Well,
video. You have to endure
these
with
things look like little cups.
Yes, correct.
Yeah, and fractures don't look like little cups. They have they're like cracks in the ice.
Yes, and
Yeah.
not always with shifts of the tectonic plates, but just cracks.
Possibly not, but you're still looking at cracks in the ice. You're not looking at little holes that are fishermen's drilled in the ice.
Gotcha. Suprapatellar pouch here, John.
Yeah.
I want to at least set this up to say an individual that spent time on your and my discussions, literally admitting to wading through all of them, if you could imagine, a very long, very long suffering man.
And I was going to say, a friend of mine said he tried to watch them, and he said, God, someone needs to edit them, he said.
Absolutely. No question about that.
Not in our lifetime, though.
That's not going to happen. And I would tell you that he is such a wonderful human that I might invite him onto one of these chats one time.
Yeah.
He sent this to me and basically said, "Where does well, let me just play it to you. This is a suprapatellar pouch, prefemoral fat pad. This is let me pull it up again here. There is fat within this synovial fluid, but there is something that is causing that acoustic shadowing from it. And he now goes short axis on it, and we see it also here. What characteristics would you give this mass here, and what would your brain be saying that is?
Yeah, the bright, heavily shadowing thing is you could call it a loose body. It could be some calcification within, because you can see all those little sort of fat globules.
These are the fat globules around it. Okay.
And it could be one of those that's become calcified. But yes, it's something that is. It doesn't. The rest of it doesn't look particularly inflammatory. So if you saw that in conjunction with a really florid, sort of low echogenicity,
oh yes,
material, then you might be thinking PVNS. But this is. But these things look a bit like loose bodies, but actually it's difficult to tell. If you looked at that with your color box on it,
yes,
then your machine would stop doing compounding, and you'd get a slightly better idea of how much shadowing there was. And also, if you drop the frequency right down, you might see that you could actually see through it, which would suggest that the degree of calcification was less marked. But this is a bit of calcification, probably within one of those fatty areas.
So your guess would not be that this could be a osteochondral defect donor island. It
could indeed be that, but it wouldn't I wouldn't necessarily be expecting to see some big lump of bone taken off, unless the story was that and the degree of what's the name? Because you get in what's the other CPPD, you get calcific deposits. You sometimes get calcific deposits. You often see them collections of them in the posterior recess of the knee. as well. So you see these sorts of things quite a lot, and they're not all chunks of articular cartilage that have come off.
I would like to again focus for just the last few seconds or few minutes on the fact that what you seemed to tell me is that if you put your processor on that is for Doppler, it
Yeah,
isn't necessarily that you want to see the hemodynamics. What you
yeah,
want to do is take out of this equation the high expensive brain using processors, so you can go back to the old
old
machines,
school. Yeah,
so
yeah,
that
and
you get the same artifact that you
yeah,
could then determine, allowed to refine what happens to a single focused sound
yeah,
wave. Is that
yeah.
correct?
Yeah, because you've got, if you look carefully at that picture you've got left on the screen there, you've
Yes.
got almost like triangular lines on both
Yes.
sides, and that's and then you get the impression that whoever's made this picture has got the balance of the gain really nicely across the image, so you're getting that nice gradient, a grayscale on either side. If he'd done the job really badly, or she'd done the job really badly and had the gain way too high, then you might actually see some material in the back behind that.
That material, however, would be generated artificially.
Not necessarily. It would just
Oh,
it would just be it would just be too weak a signal. Because what you will see, you see this most straightforwardly when you're scanning shoulders and you're seeing calcific tendinosis. And the first time you see it, it just looks like a bright, hard bit of coarse rock. And then you notice that actually you don't lose quite as much of the of the line of the humeral head underneath it. And then if you put your color box on or switch off your compounding image, your image compounding, you see that actually you're still getting some sound is going through that, even though it's a bright layer at the top. It isn't completely blocking out. But if your picture's set up nicely to see the soft tissues, bit behind that calcification will look black. But if you turn the gain up more, so you enhance what's behind there, you sometimes find that you actually get, there is actually picture coming back from behind it. And that tells you something about how
yes.
hard that, how dense that chief layer there is, and how much of it is calcium, because they can often be slightly rounded, but it's not calcium all the way through. It just looks like that from the top. It's more like a plaque on the top, but because of the shape of it, you think you're looking at a stone, but actually sometimes it's just a layer. And so if ever you're seeing that in the Achilles, it's well worth going into the coronal view, or looking in short axis from the side. And sometimes you'll see that actually what looks like a big stone is actually just a thin layer of chalk.
Amazing. John, it never ceases to amaze me how smart I feel before our phone calls, and
Yeah.
how that is inverted after we talk. Just when I think I might have handles on things, you make me aware of how little, at least of this landscape, I've grasped. I have three other studies, two of which actually had unique structures. I'll use the word mass, but I think to me that kind of conjures up sinisterness.
Yeah.
But I do have two different cases that the next time I will try to limit my talking. I also want you to know that I'm eager to have you refine any of the stuff that we got from here to include coracohumeral ligament and how it might relate to frozen shoulder or other stuff. But
Yeah.
don't feel any of this is your responsibility.
Yeah.
I will reach out again and see when you have some time to talk, and then maybe I can pull out a little bit more on the cases that I want to say, John, what is that?
I'm surprised when I'm showing my cases. If I quickly share to you before you go, and just looking at this one, do you? If I share here again, I'm just interested. I'm not interested in talking about the thing. Can you see my video again?
Yes.
Does that play like real time?
Yes.
The screen. Yeah, because yours seem very jerky, and I'm wondering if it's the software you're using to display them, because this is just in the Finder, so it's not actually. I'm not playing it through any sort of video program.
I think what you're alluding to is, Greg, you might find a application that could allow you to platform your videos in a much more easy to understand, more rapid way.
I'm just wondering whether they